The long-term play is to always keep people moving as long as they have a heartbeat.
So in chiropractic college, nobody ever tells you that 20% of your patients are going to be hypermobile. Nobody ever tells you what the vagus nerve does. Nobody ever tells you how to fix POTS. Nobody ever tells you the things we know.
That is when you have to put your big girl pants on and say, if you and I are going to work together, it can't be, yeah, we'll see.
Nobody thinks about inhibition due to scarring in the nerve and the artery, except for FSM practitioners, because we have this frequency that allows us to basically dissolve that scar tissue pain-free, quick. And it's like a magic trick.
The device is part of the success. It is not the magic machine.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
It's been such a busy, crazy, good week.
Oh, year.
Yes. Yeah. 2026 has been, I went to yoga at the end of December and they said 2026 is the year of the fire horse. And I was like, ooh, tell me more about this. And it 2026 apparently, allegedly, is about momentum. And I feel like that's maybe right. We spent a lot of time in 2025, or at least I did, planning and writing and
visioning and
yeah.
And
now I feel like those espresso machines where it's just like, it's
ready.
The fire horse is running.
We've spent the last 23 years. 2003 is when we went national in the US. 2005 is when Metagenics person changed her mind. And we stayed national. And what's happened with Kevin and the website on the back end is the ability to do the classes by remotely. And Kevin has turned it into a course. So you watch it for 90 minutes and then there are questions. He and AI have collaborated and he's almost got the 2026 course done. And then, for example, I just sent a wire to a physical therapist in Australia who's been a student, who's been using FSM since 2002. And she just taught a practicum. And we just did a practicum last week before. And it's just, it feels that way. And we're headed to London for a whole new episode in the UK with naturopaths. And I've been doing this seminar series for chiropractic students. We buy them lunch and then I get to lecture for 45 minutes. And now we're taking all 10 of them. So I did 7, Christy did 3, doing all 10 of them and putting them in a student, what do we call it? Student library?
Student portal.
Student
Portal to the student library.
Student portal to the student library. I think you should call it student library so they know where they're going. Anyway, it'll have all these videos on them. Perfect. So in chiropractic college, nobody ever tells you that 20% of your patients are going to be hypermobile. Nobody ever tells you what the vagus nerve does.
Yep.
Nobody ever tells you how to fix POTS. Nobody ever tells you the things that we know. And so we're making it available. Christy has the idea, she had the idea to do Northwestern. And today we had a Zoom meeting and she said, we're going to do it. I'm going to promote it to all the chiropractic colleges. So I went, okay. And then we're doing this course in London just for naturopaths. So I had to write a 3-day course. You know how you have to write the rehab course? I have to write the visceral course for 3 days for naturopaths and MDs, which we need. And like your rehab course, I'm not exactly sure when we're going to do it or how we're going to do it, but it's going to be done.
It's that build it and they will come sort of thing.
Yeah.
Yeah, it's growing, it's branching out. I don't know. There's a palpable energy kind of around what we're doing, I think.
I thought it was just me, but no, people
No.
are finding us. I get to tell you what I did yesterday because it's the coolest thing. It's one of those, if this patient was the only reason, because I told her she was going to end up in the podcast, if this patient was the only reason that I was born and went to chiropractic college, it would all be worthwhile. One of those.
Okay.
So she had level 6 pain, but I looked at her and said, what would it be if you told me the truth? And she said, that's about an 8, but I hate to whine. And I went, okay. So first she had a bariatric surgery where they just stitch off part of her stomach, and she lost a bunch of weight. And then she got an ulcer, and then it perforated because they ignored her. And then she got septic. And so they did a second surgery and looked in there and went, ugh. And she was so septic that they put her in a coma for 3 months and left it open so that all the anaerobes would die. And then they did a third surgery to take her appendix out. And then they did a 4th surgery for adhesions. And the one where they just left her open, it's one of those where I joke around and say it looks like they did it with a chainsaw. Big abdominal incision. And she said, they told me I had a hernia, so they put the mesh in. And I felt around and said, no, inguinal hernia, no, that's unusual in women. And I found the mesh, and they had to put the mesh in to get the center line adhesion to close, give it something to grab onto. And nausea, she's on 4 medications to stop stomach acid. And she has restless leg. One of the medications that she's on regularly was off the market for a while. It's got a black box warning. Do you know what a black box warning is? Black box warning means, look out, this is a really dangerous drug and you better have a good reason for prescribing it. And that's because it causes tardive dyskinesia. So tardive dyskinesia is uncontrollable spastic motor movements. And she doesn't need it, is the thing. She's on 3 other medications that do the same thing. So why would you do that? And she's already got restless leg, and it's just a step over the line. And I said, okay then. Looks like we need to address the vagus nerve. Why would you address the vagus nerve? What do you mean? The vagus nerve in the abdomen, because that's where her pain is. The only pain she had was epigastric and referred into the back. The vagus nerve is a pain nerve in the abdomen, so we're just going to take out the scar tissue. So I had one machine running neck to abdomen, running concussion in vagus, duh. Another machine running neck to abdomen, running scarring in the vagus. Another one running increased secretions in the vagus. Another one running scarring in anything I put my hand on, small bowel, large bowel. Another one that was running sclerosis in the omentum, and like that. And pretty soon she got sleepy, and then I'm digging around in her abdomen, and pretty soon my fingers are knuckle deep in her belly. And what's your pain? It's a 4. Okay. So then I switched one of the machines to 40 and 89. What's your pain level? It's a 2. Okay. Does it feel weird? Yeah. So I did increased secretions in the sensory motor cortex. 40 and 89 is because when you've been in pain for, I think it was 4 years, at that degree, with that many surgeries, there's a lot of trauma. So I ran trauma in the digestive system, and then quiet, all those bad memories in the midbrain. We did run TTH twice because stupid surgeon, nobody should have that many surgeons who do that many things. That's just not right. So we ran TTH just in case. And then at the end, her pain was a 0. And her belly was soft. And we taught her to walk again. And I said, I don't know what she said is going to come back. And I said, maybe. But if it worked once, it'll always work. And I don't think you're never going to be that bad again. And she was taller. She didn't hunch over like this because of the scar tissue. So I have 2 more days with her. But it was like, oh, yeah, this is why we do this, because we change lives big time.
How long are your treatments typically? Like how long each time was that?
This one, if I had an hour, I could have done something, gotten her from a 6 to a 4.
Yeah.
But I didn't have anybody after her. And we started at 12:30 and finished at 4:30 or 5.
Oh, wow.
And part of it was just talking and making her comfortable. I'm the only doctor she's seen that hasn't been scary, holding sharp things. And so it was, yeah, you could have done it in a bunch of half-hour treatments, each time bringing her down. If you had as many machines, you had to run 40 and 10 on one machine for spinal cord sensitive. No, actually, because abdominal pain doesn't go through the spinal cord, as far as I know. It goes straight up the vagus. Any pain that's in the abdomen just goes straight into the brain, straight into the medulla, and straight up to the vagus. It doesn't even go up the spinal cord. So do quiet the midbrain to tell it to calm down, reduce central sensitization, and turn up the vagus.
Right.
I'm convinced that it is essentially a denervation injury when they have that many surgeries and that much trauma to the vagus.
Right.
But then just the scarring everywhere. The duodenum, the stomach, the vagus, the peritoneum, the everything.
Did you run the 58s at all?
No, didn't do it. I'm bad. I didn't.
It's not being bad. I don't think they work. And the only place I would find them quasi useful was the viscera. But to your point and to what you just described, you didn't even treat using 58s and you pretty much had a slam dunk treating the vagus. And
And I just kept going because it was fun. And she's one of those people that had the attitude that I'm going to get better. This is going to work. They found me because of a friend who told them about FSM. We have something different.
I want to say about the mindset of going into a treatment with this is going to work. I'm not sure if it was on the podcast that we had with Dr. Massey or when we brought him to Arizona, or if this just came up in conversation, but there was essentially a patient that like he invested so much time into strategizing what he was going to do. And then the patient was like, yeah, we'll see. And he's no, not we'll see. This is going to happen. And that point of making the decision, do I even go forward with this? Because he's not in alignment. And when somebody's, yeah, we'll see, or this will probably just hurt, or it's going to end up the same. That is when you have to put your big girl pants on and say, if you and I are going to work together, it can't be, yeah, we'll see. And it's more than just that fear of movement. This is a self-fulfilling prophecy that everything that they were going to do is going to fail. Because and I understand that it historically had. But now in my practice, I do a 15-minute Zoom call, not a phone call. I want a Zoom call. I want eyes on the person. I want to look them in the eye. I want them to look at me. And we have to come to an agreement. If we're going to work together, these are my expectations. And part of it is getting a feel of kind of what the past trauma was physically and emotionally, and what we have to kind of work against if we are going to
Yeah.
work together at all.
Yeah.
And I don't get as many hours as you do. The practice that I have joined in San Jose goes quick. But these Zoom calls have really saved me a lot of time on the back end, where I can not just get a history. And a lot of people are like, where do you have my chart? I'm like, I have your chart. I have your MRI. I have all the things that you've tried, but I want to hear it in your own words.
Yeah.
And I think that's really important. It's one thing walking into a treatment expecting bilateral wrist joint pain, and it's another thing hearing what they're missing, why they're frustrated, the exact movements that cause the pain, the exact movements or the exact strategies that make it better.
And that way they can show you
Yeah.
what, and it's different for everybody. And see 85% of human communication is nonverbal.
Right.
So you can see in their face, and unless they're in alignment, unless they have buy-in that this is different than anything they've tried, different than anybody else does, and they need to have at least some positive expectation, positive outcome.
Right.
Like,
It's amazing. I've always been in the camp of undersell and overdeliver.
yeah,
But I also want to set up realistic expectations as well. So they're like, when should I notice a change? I'm like, the first treatment, we should notice something. They're like, what? After one treatment? I'm like, you're not going to be cured in one treatment. But if I don't make a dent in the pain in one treatment, something's wrong. I go,
yeah.
but this is why we have the Zoom call. This is why the patient history form is 7 pages. This is why it took so long to get in to see me, because I need to call everybody that you have seen before and figured out what worked and what didn't.
And why?
And why. And then when I explain what we do, and they ask a lot of questions about the device, and I said, the device is part of the success. It is not the magic machine. It's what we tell the machine that what needs to be done. It's the information that we share in the appointment, the biomechanical assessment that will tell me another piece of that puzzle. And we're just putting a puzzle together.
And the machine just delivers. It almost sounds like you're afraid to tell them what you're doing is changing frequency signaling within cells within the body. I mean, that the machine just delivers the frequencies. The frequencies do the work. When you have a published paper that shows that you went from 2 millimeters of knee cartilage to 5 millimeters of knee cartilage, and they have an MRI to prove it, and they did that by running frequencies for vitality and increasing secretions in the cartilage, you know that we're doing something. We have this published paper, and the frequencies do that with delayed onset muscles. So, you know, you're doing something.
My point is that they're not locked in a room with a device that their PT scared or left them with.
Yeah.
And for the athletes that I see, whether that athlete is a professional or a retired police officer that used to play soccer, I guess the point that I want to make is that it's not just a machine that does one thing like bone stem or TENS. It's so much more, and its success is based on the information that we discover as a team.
Yep. Yeah. And we work as a team.
Right.
Your body and me.
Yeah, it's a collaboration, I think, unlike anything else. And maybe that is also part of the success with FSM, that we You said it, the first core I went to, it's not the muscle. And those of us who, that's all we were used to treating, poop your pants a little bit because you think, what am I here for then? If it's not the muscle, that's all I can treat. So it's unlocking and opening up all those doors to think beyond the tissue. And to me, that's what I'm most proud of as an FSM practitioner is I'm never stopping to ask why or how. How did we get here?
And we have the ability to treat the cause. It's not the muscle, because the muscle relaxes when you treat the ligament. The muscle relaxes when you treat the cartilage. I have a Ehlers-Danlos patient in New York who was seeing an FSM practitioner in about 2 hours away. And he said, now make sure you tell Dr. Carroll not to run frequencies that are going to relax the muscle, because that's going to make your neck less stable. And he really said that. And he's a DPT. He's okay. So here's the thing. When we run the frequencies that are correct, that repair the ligaments that are injured in your neck, it will soften the muscle. But before you get off the table, you have to exercise the muscle. And I showed her how to do the exercises. Close your eyes, turn your eyes to the left, turn your eyes to the right. Oh, the muscles back there contract. Yeah, and until they're soft, they can't get strong. So you have to treat what's causing them to be tight, and that is the fact that the ligaments are torn and broken. So we repair the ligaments. The muscles can go, oh, thank goodness, now I can let go for a minute. And then while they're relaxed, you teach them to contract, and you start building strength, which builds stability.
Right.
And that concept is so completely foreign. So that I was a little concerned when I have a student that has been doing FSM for about 10 years. And he must have, I'm hoping he took the course before I changed how I was explaining what we were doing. It's like same thing with the sets and the ligaments in her neck. Muscles have to relax. And these are the exercises you do to strengthen them while they're relaxed, because you can't go from contract to contract. You can't strengthen from a point of spasticity. So
it's taking the diagnosis and the situation one step further by asking the how and the why. So yes, the muscles are tight because they're protecting lax ligaments. Okay.
Yeah.
Let's go after the lax ligaments. So then the muscles don't have to freak out and do splinting that's unnecessary. That's the only way rehab is going to work. A muscle is not going to fire and wire if the situation is unstable or has pathology. We know that. That's why we don't stop by saying something is weak. You cannot say that. You cannot say the glutes are weak. The erector spinae group is weak. The psoas is weak. Stop it. We have to stop saying things are weak. Something is potentially inhibited due to X, Y, and Z. And that is your job. Your job is to figure out why something is inhibited. And that's where the success comes from. Otherwise, you're just, what's your saying, shooting the boat and bailing it out and whatever it is like.
You can't keep shooting holes in the bottom of the boat and no, you can't bail out the boat while you're still shooting holes in the bottom of it.
Yes, that.
Oh, what was that other thing you said about?
Hard to believe until it's impossible to ignore.
Hard to believe.
It's already on the website.
Kevin says it's already on the website.
Uh-huh.
Until impossible. Yeah. Wow. It's hard to believe until it's impossible to ignore. It's in orange on the website header page.
It's my favorite color. Good job, Kevin.
Anyway.
So again, it goes back to change. It's not a list of frequencies. It's not just some device that runs on its own. It's more than the mode bank. There's so many things that I know that we probably say every podcast, But until we reach all the corners of the universe, like that practitioner that says, don't take the tension out of the muscle because of whatever. Yeah, we just can't be lazy, I guess, is the point. You talked a little bit about 40 and 89, and I know we talked about it the last time about patients who get worse with 40 and 89. Somebody had written something on the Facebook page, somebody had emailed me, and then somebody brought to light one of the slides from the core about making 4089 can make patients worse. So I think the point is that you're saying it doesn't not happen, but there's just that precaution that is there.
It's the same. I've had to eat my words. Increasing secretions in the midbrain. I made a guy in a coma cry. I said, okay, I don't know where that's from. So that's why you keep explaining things over and over again, because I guess people need to hear it 7 times before they hear it. That is, the normal function of the midbrain is to suppress pain.
Yes.
Right? You bonk your shin on a table, on the coffee table, as we do, and the pain spikes up, and then it goes down right away. The bone bruise that you got or the bash you got on the periosteum isn't gone. It's the midbrain that, in our world, that midbrain is suppressing the pain. That's the normal function. So if a patient is really good at suppressing pain and you run the frequency to suppress pain, suppress the midbrain, and you're suppressing the ability of the midbrain to suppress the pain. And if the patient's pain goes up, so this is the thing, if the patient's pain goes up when you run 40 and 89, it means that the patient is using their midbrain to suppress pain. So then you can do a drive-by on 81 and 89 until it comes back down.
Right.
And it's really interesting. I don't know if people hear what they want to hear, or if once they hear one part of it, they stop listening because it's a new concept. So once I say that the job of the midbrain is to suppress pain, and if they're suppressing pain and you run a frequency that takes their pain away, there's nothing to suppress. Pain can go up. It's okay.
Yeah. And that is in the core. I'm looking at a screenshot of one of the slides right now. Slide 88, I believe I'm looking at. It took us a little
early
bit.
on.
Yeah. So there's nothing I think sometimes the thinking is very extreme. If this is causing pain, don't run it. Don't treat the muscle. It's going to make it unstable. Don't treat that. So there's never anything I have found that is that extreme. It's diagnostic. It tells you a story. So yeah, when you have a patient and we think it's like that part that's afraid to move and we run 40 to 89 thinking that's going to help with motor repatterning after, but their pain goes up, it's not run out of the clinic screaming, hair on fire. It's okay. Pain went up. All right, let's try this instead. Pain will go down back to baseline and then continue on. There's an antidote that's not so scary.
It is rare. I wouldn't say it isn't possible, but it's rare that event happens. And maybe I shouldn't warn people about it at all, but
I think it's good because I do think it does happen, even though it's rare. But
I want them to start thinking about how the central nervous system works with pain management and with musculoskeletal pain, or what we think of as musculoskeletal pain. One of the reasons we have Jay Shaw come is that aside from showing movie clips, his wonderful graphics are about how pain is sensitized as it goes up the spinal cord and turns the little goat paths of pain signaling up the cord and in the brain into 3-lane freeways. How that happens. And one of the things that happens with FSM practitioners is it's time to start thinking about how the central nervous system and the peripheral nervous system work together to create your experience of reality. And you're not just treating a shoulder.
Yep.
You're treating the brain, you're treating the digestive system, you're treating the adrenals, you're treating the emotions. You can't just treat the shoulder.
No.
You have to treat the shoulder because that's what's wrong, but you're not just treating the shoulder. So I would love to be able to put all 963 slides all at once and just put them in your head. But I can't. So we take it a little piece at a time and we introduce those little tidbits a little at a time, so that maybe that's where people get hung up, because it's such a unique idea. Wait, what did she say? I was looking at the bird outside. What about the midbrain? About central?
Yeah, it is a lot, and you can't expect everybody to retain everything all at once because it's not just a list that you memorize. However, I think practitioners, and whether they're young practitioners or seasoned practitioners, sometimes we fall into a bit of laziness with our diagnoses, with our assessments. And every time I've cut a corner, even a little one, it has come back to bite me in the bum because I needed that range of motion. I needed that sensory exam. So a lot of times, like when I'm teaching the rehab course and people are looking at active, passive, and resisted range of motion, and they're giving me the eye roll, I'm like, I get it. You did this day one of biomechanics class, but how many of you do this now? And a third of the class will raise their hand. I'm like, you have to go back to an objective measure, because pain findings is great when the pain goes down, but we need to document and measure the changes in range of motion. That is how we know we are objectively doing what we think we're doing.
And it's also how the patient, it's interesting, it's how the patient knows that you did something.
Right.
So the patient, I love the patient, you're treating their neck and they come in with a rotation of 45 degrees in each direction, maybe 50. And you do the supine cervical or some modification of that. And they turn the head and they say, it still feels stiff. So you're turning your head 90 degrees to the right. If you didn't feel stiff, your head would fall off. Because I measured the range of motion before and after. I went from 50 degrees to 90 degrees, and the normal range of motion is 70. So it's going to go back to 70.
Right.
And feeling stiff is normal at the end of range of motion.
We talk about goal setting all the time in practice. What are your goals, short-term, long-term? In my practice, we talk about the short-term play and the long-term play. The long-term play is to always keep people moving as long as they have a heartbeat, whether that is up and down a chair, up and down off the toilet, playing pickleball, you name it. We want to keep moving. That's what we're designed to do. The short-term play obviously is getting somebody out of pain, right? You're not going to keep an active lifestyle if pain is present. So the short-term goal is always getting them out of pain. And I'm not sure how much of your practice is like this now because you see so many out-of-state people that come in to see you. But I've been working with some people now for 6 years. And we had a meeting with one of my patients the other day. And I'm still pretty frustrated with everything. I'm like, okay, let's go back and think about when you first came in. You were 25 pounds overweight. You barely did anything because of the pain. Now you've lost the weight. You're playing golf. You're playing recreational football. You've joined a tennis team. You go to the gym. You're able to work more hours. You're not on medication anymore. And then he's, oh, right. Yeah, I forgot about all of that. So sometimes you have to take people back when and it's great to be always moving the goalpost and trying to do more and more things. But I think sometimes it is having the conversation of going back to the beginning and saying, do you remember how much pain you're in?
Yeah.
The walker or the cane that you had that you don't anymore. Like,
This becomes the new normal.
Right.
The new normal is a 2 instead of a 6. And then they notice the 2 out of 10.
Right.
And they're frustrated because they want that to change.
Sure.
Okay, you're doing a lot more and your pain is just a 2. What would you like to change? Let's see what we can do. Speaking of inhibited, somebody came in. I thought of you yesterday. She's one of my local patients. I've been seeing her for 25, 27 years.
Wow.
And she said, yep, I'm in PT and they're trying to strengthen my glutes. My hamstrings. They say my hamstrings are working too tight. Why would your hamstrings be working too hard? My hamstrings are working too hard because my glutes are weak. And then that story from the core came floating up into my head. And I treated the adhesions in her femoral plexus. And she went, ow, what is that? Ow, what is that? Ow, ow, where'd that come from? Both legs. She hasn't had any surgery. I don't know why they're inflamed. She's got rheumatoid arthritis. Maybe that's it. But I took scarring in the nerve, scarring in the artery from her groin down to her knee. And then, what was the other thing? Her external rotators weren't working. And that was because the internal rotators were what the nerve and artery were glued to. So the adductors were tight and everything was internally rotated. And so we got her to externally rotate with getting her piriformis to work. And then I went and put her on the reformer in the gym. And she said, I have a butt. My glutes are contracting. How cool is that? How'd you do that? You did that because the glutes were never weak. They were inhibited.
Right.
And it's that story from the marathon runner in Australia is classic. And it's
Yeah. No, but part of it is also common sense, right? I also run 20 miles a week. My glutes are not weak. My hamstrings don't work too hard. Again, that's I'm getting angry because that's a really lazy diagnosis or assessment to throw out. It's taking it one step further. Okay, maybe something is inhibited. You do a strength test and something doesn't fire left versus right. So you can see, again, it goes back to the assessment. Active looks off, passive looks symmetrical, resisted back to off again. Okay, something is not firing the way that it should. And that's where people stop. And then they're like, do these exercises. Do you think if there was scarring in the femoral plexus or in the hamstrings, in the sheath, in the fascia, which is very common, do you think for a second something is going to fire if there's a risk of a tear happening if it contracts? No. It's the same as a bone spur. It's the same as so many other pathologies.
Yeah,
So
but nobody
why.
thinks that way except us, because there's a frequency scarring on the nerve, scarring in the artery. Nerve, artery, vein travel together.
Right.
And nobody thinks about inhibition due to scarring in the nerve and the artery, except for FSM practitioners, because we have this frequency that allows us to basically dissolve that scar tissue pain-free, quick. And it's like a magic trick because the patient gets up off the table and they can contract the muscle that was inhibited. And so all you have to do now is strengthen it. So come to the gym and get on the reformer and contract your butt.
Right.
Oh, and then I taught her, we started her out with 2 springs, just pushing back and forth so she could activate her butt, glutes. And I said, now externally rotate your feet so that we can make your performance fire. And I said, you want to have fun? And she said, what? What are we going to do? What? So we're going to take you down to 1 spring and I want you to jump. So she comes down on the reformer with both of her feet on the board. And I said, just push off and fly. And you push off, so you lower the weight so they can. And And she went, wow, this is fun. So,
And that joy, that wow, this is fun, that freedom, that is where things start to fire and wire together because they're not afraid. It's not scary. It's not painful. And that's how a pattern starts. A true pattern. Patterns will never stick and hold if there's fear or pain present.
yep.
And more trainers out there need to understand that concept because that's how people get hurt. Because that's when suboptimal firing patterns happen because one muscle is, I am not doing this. This is going to cause excruciating pain. I'm not participating. And then the other muscles are like, okay, fine. She's not going to stop. We'll do it. We'll help.
Do you remember the patient we worked on where they decided that his quadratus lumborum was weak? So they kept doing exercises to strengthen it until they tore it to the point that they had to do surgery to repair it. And then a year later, you and I came in and found out that he'd fallen on his back and the kidney was adhered to the quadratus lumborum. And that's the reason it was inhibited, not weak.
How could
And
I ever forget that? That was a gift because that's what prompted the whole wipe and load. That was when that was created because of that one patient.
yeah, you learn so much every time. So much fun. I have to answer Leaf's question.
Oh,
We have
yeah.
one question. Yay. Everybody else must be really happy today because there's only one question. And it's easy. What do you know about treating adenovirus? That's a common cold and all of its friends. There is common cold sinus. And the first time I ran that, you just put a washcloth over your forehead and another one on your throat. And the current goes through the frontal and the paranasal sinuses. So there's 3800, 3830, and 3833, I think, are the three Abrams frequencies for common cold. And then we run congestion and allergy reaction, and then the very last we run inflammation. And you run that, if you run it when the cold is just a whisper, when you get the little tickle and the little scratchy thing and you feel tired and you really want to go to bed, that's if you run it then. Take 5 grams. I take 10 grams, but I'm weird. So take 5 grams of vitamin C, chug about 50,000 units of vitamin D, and go to bed 2 hours early. Run common cold sinus, and the next day it's gone. If you wait until it's established and you decide that your stuffy nose is not just because there's dust bunnies under the bed, that I have a cold. Okay, so there's a picture of Marilyn Miller when we went to the PT school where she taught. She had a cold, a sinus cold. And I said, and you're not running FSM because why? Huh, I forgot. So I have a picture of her with a wrap around her neck and a graphite glove wrapped in a wet paper towel on her forehead. And by the time she finished running it, it was gone. It was gone the next day. It was done.
Right.
Then there's common cold throat, and that I rode, had to be 2000, as soon as we got the custom care, so 2007, and I was on the road in some out of town city and hit my throat. Viruses have to jump on me in the middle of the night when I'm asleep, because otherwise we fight them off. So middle of the night, I wake up with this burning in my throat. That was back in the graphite glove days. Put a wet graphite glove on my neck, another one on my throat. It was the auto care. Push the button, get to common cold, throat, push the button, go to sleep. When you wake up 2 hours later, push the on button, run it again, and in the morning the sore throat was gone. Then I found out that if I get rid of the cold in the sinus, The next day it's down in my throat. It's got to go someplace. So we now have common cold combo that does both of them at the same time. Just shut them all down.
Right.
It was pretty fun. So yes, I know something about treating colds. It's really fun. It's showing off. Patient has little or no appetite as a result of pain due to 4 compression fractures in the spine. Oh, poor baby. Yeah, you obviously treat the fracture. Those are in the spine. Part of the appetite is not because of the pain so much. Those are really painful, though. So you treat the fractures in the vertebra, but T12, there's a big sympathetic plexus there, and the sympathetics turn off the vagus, and the vagus controls the appetite. You run concussion and vagus. And if you have multiple machines, you have one machine that just runs increased secretions in the vagus for however long you're treating the fracture, which is about 50 minutes. And you have her coming back 3 times a week, wear her binder. So they put them in a brace that stabilizes that area so they can't move it. So the fractures will heal. Make sure they're not stenotic in the lumbar spine. But basically, appetite, when somebody says appetite, think vagus. And then there are times when you can't keep the vagus on because it's time for it to be off, right? For it to be off.
Yep.
You're busy with a broken whatever, or with a cold or with an infection, and it's time for you to eat little teeny meals and not feel like eating. That's just fine, because the brain can turn the vagus down faster than we can turn it up. Sometimes
she just mentioned here, she just finished antibiotics for a UTI.
Yeah, that's okay. The antibiotics, don't have much. UTI at least is gone. That's good. And then you start chasing down, how did you get compression factors? What are your vitamin D levels? How did you get the compression factors? That's a lot of compression factors all at one time. T12 is the most common compression factor. It's almost universal. All they have to do is sit down hard. If they're osteoporotic, they'll sit down hard and they'll break L12, T12. L1 is the other one. But L1, 3, and 4, what did she do? How did that happen, and how are they treating it? Is anybody treating it? Are they planning anything scary like putting rods in? Or are they just going to let it heal? And believe it or not, orthopedic surgeons do not check vitamin D levels. At least mine didn't, the one that worked on my shoulder. And he was a new graduate. And I said, what are my vitamin D levels? And he said, what are my vitamin D levels? He said, I don't know. And I said, why don't you know? And it was like PTSD. It was back to residency, because you're never allowed to say you don't know. You can be the best surgeon in the world, and if my vitamin D levels are 12, this is not gonna. Yeah, taking calcium, that's not helpful, because her sympathetics aren't working. No, because her vagus isn't working, because T12 is broken. Now you got to follow this. Okay, you with me? Okay, here we go. T12 is fractured, and that's sympathetic stimulation. So you take the sympathetics and say, there's a fire, okay? And then that turns down the vagus. The vagus is what turns up stomach acid. You can take all the calcium you want, and unless there's stomach acid, it's not going to be absorbed. And believe it or not, some people take calcium carbonate, which is not absorbed at all. Calcium carbonate is an antacid known as Tums. And because it has calcium in it, people think that it is a source of calcium. Because I used to sell effectively Tums, it had a different name, but calcium citrate, calcium. Okay, You can even look this up, Linda. Calcium citrate is what they use as a laxative because it is not absorbed at all. Like, not at all. In order to balance the calcium on the outside with the calcium on the inside, the body puts more water in the colon to thin out the amount of calcium. And that's why calcium citrate is a laxative. It's not absorbed. There is a product, New Chapter was the one I took because for fractures, you need more than calcium. And she's not taking any calcium that works. New Chapter makes a product called Bone Strength that has selenium in it. And there's an herb called horsetail, whose major component is selenium. Magnesium, I can't remember which version of magnesium, phosphorus, and calcium malate, glycinate maybe might be absorbed. But the product is called Bone Strength, and it's got a little bit of vitamin D in it. But the papers that I read, as soon as you fracture something, almost immediately your vitamin D levels start going down. The body uses vitamin D to repair fractures. It uses it. So she's already using up whatever she had, and if she was low to begin with, and if they didn't check. So you take a liquid made by, let's say, somebody like Thorne or whatever, that's D3 and K2, and you know where it says to take 2 drops, you just put it in your mouth and you chug about a teaspoon of it 3 days a week for the first 3 weeks of the fracture. And it'll heal in about 4 weeks as long as you're running acute fracture on an FSM program back to front. So you're going through the fracture. And yes, if they've got her in a brace, you can use the magnetic converter or sticky pads. That would go. If fractures are, I was about to say fractures are easy.
I can't say that, but they really are. Like that is, it's pretty easy.
4 weeks. And the appetite thing is you can turn the vagus on, but explain to her that she doesn't have an appetite for a very good reason.
Right.
And if she gets hungry, then you can run concussion in vagus, and that would be the way to take care of that. I don't know, maybe stay on for an hour so she can eat whatever she wants to eat, and then it'll go away again. And you know that the fracture is healed when you're hungry.
The injury apparently was lifting a moderately heavy box.
Okay, that's how she cracked L3 and T12. Something else happened. There's no way to do a compression fracture like that without doing something more. I had a patient that had a compression fracture at L3 just because he was pretty osteoporotic. He was 85 and he sat down hard on a plastic chair. That was it. And just squished L3. Poor thing.
Or L3. Oh.
Yeah. And what's fun is when you look at it and go, okay, you put all the pieces together.
Yeah.
You take this and then you take that because metabolically that's what you need. You need selenium, you need calcium, you need stomach acid. So you have to turn the vagus on at least part of the time.
Yeah.
You're not going to take calcium carbonate. You're not going to take calcium citrate. You are going to take selenium. You are going to wear a brace, and you are going to use FSM. And then in 4 weeks, it's kind of sort of healed. Should be.
Yeah, I like how you emphasized it's not just FSM and nothing else, right? FSM is not the gatekeeper. We play nicely in the sandbox with everybody. And kind of going back to how we started, that's what good teamwork is all about.
True story.
Yeah, I want to make sure that we got through all the questions. I think we did. Linda says, thank you.
Yeah. You're
And we got to
welcome.
all these things. Leaves comment, thank you. Why didn't the MDs call it a simple cold? Because adenovirus just sounds like
Some
more complex and scary. I don't know why that would be helpful in that situation.
The nice thing is these days, Ben Catholi has a mug that says, "Don't confuse your Dr.
Google.
Google with my,"
Yeah.
right?
Yeah.
But if an MD uses a word like adenovirus, all I
Yeah.
did, just to make sure, I just searched adenovirus and it said the virus is associated with the common cold. Okay, I didn't miss anything.
Right.
And then they don't make the PDR anymore. So when I'm pretty sure it was Reglan, when they put this patient on Reglan about a month ago, and I Googled Reglan, if there's something about that, this, okay.
Wow.
You don't get to take that.
Right. And,
Or you can ask your doctor why see right here, black box, and I have twitchy legs. And then you Google, you can search for tardive dyskinesia and see if that's something you want to take a risk about. Pre-medication, everything we do is a risk-benefit balance.
Right.
Yeah.
Yeah. And that's it. And we started a bit early and we're ending probably 2 minutes early. But because we have 2 minutes, I will always bring people back to the website for continuing education and all the great resources that we have on there. So there's a lot of practitioners that have been reaching out that have either taken a course a long time ago or practitioners who are thinking about starting their FSM journey. They ask, where should I start? The podcast, and somebody asked, well, do they go in order of anything? I'm like, oh no, over 200 episodes of just jumping around topic to topic, multiple topics in 1 hour, unfortunately. So yeah, go back and watch us from day one.
And on the website, there are podcasts going back 10 years. Not podcasts, webinars. Webinars going back 8-10 years.
Yeah.
Before I started doing the theme ones, the Vegas, Ehlers-Danlos, mold, those three are the big theme ones. Before that, it was webinars about case reports.
Right.
And I think those were so valuable. When I go back sometimes and look at them, just look at the slides. There's one that's called Take It Apart, because there was this complex, scary patient, and the only solution is you take it apart. How did it start? Where does this symptom come from? Where does that symptom come from? This is referred. My leg is numb. What's this pokey wheel feel like? Oh, it's just prickly. Okay, then your leg isn't numb. There's to it. Feels funny. It feels numb. Okay, that is called paresthesias. It feels as if it should be numb, but it's not. Oh, because you can feel that, right? Yeah, it's sharp, it's pokey. Okay, then you can feel it, fine. But it feels numb. It feels fuzzy. It feels as if it should be. And that means it's coming from the muscle. Right. So show me where it hurts, where it's numb. Anyway.
And that's just, again, going back to not just settling for what the easy way, numbness. Explore the numbness. Ask more questions about the numbness.
You got it.
And now the alarms are going off and the dog is getting up. So it is 4 o'clock.
It is 4 o'clock. Yeah.
All right. We'll be here next week. Same time, same place.
See you then.
See you then. Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.